So this is really kind of a cool opportunity for a urologist to get to talk about a topic that's near and dear to the medical oncologist. So I'll give you Seth Lerner's hopefully evidence-based spin on this. As I've showed you before, these are my disclosures, and there's nothing on here that's relevant to what I'm going to be discussing. So the way I've got the talk organized is just to provide a very brief rationale as to why we would integrate systemic therapy and definitive local regional therapy, in this case radical cystectomy, the evidence supporting NAC or neoadjuvant chemotherapy, the limited evidence supporting adjuvant or postoperative treatment, our current approach, which is one size fits all, and some glimpses into precision medicine approaches where we hopefully get the right treatment for the right patient. So this group is well acquainted with the natural history of urothelial cancer. Roughly about a fifth of patients with non-muscle invasive disease will ultimately progress to a muscle invasive cancer, yet the majority of patients who are diagnosed with muscle invasive cancer present de novo as their first experience with bladder cancer. Distant metastasis are clearly the most common cause of treatment failure and subsequent death, and there's been little improvement in overall survival probability in the last 2 to 3 decades, and that's likely to change with some of the innovations in new drug development and immunotherapy that we've been talking about most of the day. So this is really kind of the tragic state of affairs. You'll notice the publication date in 2005. This was you're familiar with this, randomized trial of MVAC versus gemcitabine cisplatin in measurable metastatic disease. So the planned treatment was 6 cycles. It was designed as a non-inferiority trial, and it shows that essentially the take-home message here is that if you look at the 2-year time point, roughly about 80% of the patients have died, and you've got this long tail of the curve, so we're curing a small percentage of those people. Most of those patients have node-only disease, where you get a 30% 5-year survival probability, and quite frankly, not much has changed, although I think the IO era has some promise, at least for a percentage of these folks. This also has been the justification for moving gemcitabine cisplatin into the neoadjuvant or adjuvant space in the absence of level 1 evidence supporting it. I'll go through that in a little bit down the road. So what are our integrated treatment options? Well, there's been a lot of work historically about using preoperative radiation therapy. The take-home version there is that, or the take-home message is that there were really no randomized clinical trials in urothelial disease that showed a benefit to preoperative radiation therapy, although there may be some benefit to locally advanced pure squamous. The perioperative chemotherapy options are neoadjuvant, prior to definitive therapy, or adjuvant postoperative. Historically, about 12% of patients received it, and it was mostly adjuvant. That needle has been shifted really over to neoadjuvant, and in our S1011 randomized clinical trial of extended versus standard node dissection, 56% of the patients got neoadjuvant chemotherapy, and 88% of those were cisplatin-based. Now, that's in the academic centers, and probably a little slower uptake in the community, but it's certainly on the uptake. And that you heard in the guidelines talk from Sam that level 1 evidence really is only supporting cisplatin-based neoadjuvant chemotherapy. There essentially is no role for non-cisplatin neoadjuvant chemotherapy. Remember that neoadjuvant implies no measurable metastatic disease. If you're dealing with a patient with node-positive disease, my opinion is that they should be treated with 6 cycles of chemotherapy for metastatic disease based upon the trial that I just showed you. So why neoadjuvant? So the idea is that we're dealing with a systemic disease, often with a systemic disease, and to give systemic therapy up front before the patient has any kind of debilitating, even temporary toxicities from the definitive local regional therapy, most usual cystectomy. You do have a measurable disease in the bladder, so it gives you something to get a readout on the effect of your chemotherapy, treat the micrometastatic disease up front. In a slightly different paradigm, if you've got a bulky tumor or a T4B tumor, which is fixed to adjacent structures, you may get, or simply a big T4 tumor, you may get some downstaging, and that may help the surgeon with the intraoperatively with the tumor. I'm sorry, with the cystectomy. The disadvantages are fairly obvious, and you'll see that on average about 40 to 50% of the patients benefit from this, which means that at least 50% of patients are getting toxicity without benefit and potentially delaying definitive local regional therapy. And that's really the bugaboo of one size fits all. So if you can readjust the timer here. I'm not down to 4 minutes, I don't think. I talk fast, but not that fast. At any rate, so if the urologist, and certainly nobody in this room, but if anybody has any skepticism about whether this stuff works, the top two trials are large randomized trials. First, the MRC International trial was over 900 patients. The SWOG trial, roughly just shy of 400. And there was an unequivocal benefit to the chemotherapy as evidenced by PT0 rate after cystectomy. So we know that on occasion the TURBT is complete, and we would expect and tell patients about 10 to 12% of the time there won't be any residual cancer in the bladder. So we expect that. So in the context of a randomized trial, presumably balancing any kind of unknown contributing factors to this, you have nearly a tripling of the PT0 rate directly due to the chemotherapy. So it's unequivocal, it's undeniable, it's there. The magnitude of that benefit in other series and some retrospective may not be on this scale, but we're powering our clinical trials around this magnitude of benefit. So unequivocal benefit, at least as measured by P0 rate, and I'm going to show you in a second that may be a reasonable surrogate biomarker for PFS and overall survival. The other thing is that there's benefit in both clinical T2 and clinical T3, T4 disease. And this is just a stratification within the SWOG study, which shows very nicely. I've got the median survival comparisons there. And so the current school of thought, and not every institution follows this, is everybody with a muscle-invasive cancer should be counseled by a medical oncologist about the risk and benefits of neoadjuvant chemotherapy in the context of a multidisciplinary team evaluation when we're dealing with definitive management for patients with muscle-invasive cancer. This is a priority, the very top line in the ASCO guidelines, and they took the EAU guidelines and sort of made their own guidelines on that basis. And as Sam showed you before, it's front and center in the muscle-invasive guidelines for the AUA. So I would argue fairly forcefully that this really is the standard of care. Now, what do you do in a patient who comes to see you and they have an EGFR of 40? And you know that they're not going to be able to get cisplatin-based chemotherapy. Why send them to the medical oncologist? Well, I still think there's a benefit there because there may be circumstances, let's say they have an obstructed kidney, you put a PERC or a stent in and their kidney function may improve, or their kidney function potentially could improve after surgery, and it's good to have the medical oncologist on board anyway. So just sort of how we're trying to do things operationally at our shop. Meta-analysis, the magnitude of the absolute benefit is about 5%, and again, it's only accrued to multi-agent cisplatin-based chemotherapy regimens. And this is just the KM plot from that particular meta-analysis. And you could look at that and say, gee, really? I'm going to treat 100% of my patients with this toxic chemotherapy for an overall benefit of 5%? And the answer to that is the identical magnitude of standard of care adjuvant therapy in other organ site cancers, breast, colon, for example. And so we cannot ignore level 1 evidence out of convenience. And I apologize if I'm sounding like I'm lecturing, I guess, which I am, but I just want to share with you sort of at least a particular viewpoint that's shared by quite a lot of people in terms of why we should be using this. But it also speaks very clearly to that we have to do a better job. We have to identify the patients who are most likely to benefit from this so we don't overtreat patients who clearly are not going to get a benefit. And this is just the sort of an amalgam of the guidelines from the AUA, EAU, and ASCO. Level 1 evidence supporting it, strong recommendation from the AUA. And then it's interesting that the use of gemcitabine cisplatin does not have the same level of evidence, but I have to say that it's been sort of a convenient regimen for the medical oncologist to use with the perception of less toxicity, but actually that's only when you're looking at 5 or 6 cycles of treatment. I would argue that the relative differences in toxicity with 3 or perhaps 4 cycles compared to MVAC is not as great, and there's still a lot of medical oncologists that are using MVAC, but suffice it to say that MVAC and GC are the most common regimens. Well, what about adjuvant? So unfortunately, the quality of the evidence is not so great, in large part because there were 3 big randomized trials in Europe, Spanish, Italian, and EURTC. None of them really completed accrual. And so we don't really have good evidence. Cora Sternberg led the EURTC trial, published this paper in Lancet Oncology a couple of years ago. Just keep in mind that this is perhaps more hypothesis generating and giving us some insights because the trial did not accrue completely and was closed early because of that, but the benefit, at least in adjuvant, appeared to be in that study from node negative rather than node positive disease. But what's interesting is you do see that the node positive patients have about this 30% 5-year plus survival probability. So it's clearly curative disease. And then an updated systematic review and meta-analysis shows roughly the same magnitude of benefit as we see with neoadjuvant chemotherapy. So in a setting where a patient, for whatever reason, doesn't get neoadjuvant chemotherapy, has high-risk disease post-cystectomy, certainly any residual muscle or perhaps T3, T4, or any positive nodes, we are recommending adjuvant chemotherapy in that setting because of the belief that the data is good enough, and bless you, we want to try to do the best that we can to help the patient enjoy long-term survival. These are the guidelines as they relate to adjuvant therapy, and it mostly really accrues to patients with PT3, PT4, or node positive disease. So what about the future? How do we kind of move beyond this one-size-fits-all approach? Well, I'll talk a little bit about prognostic biomarkers. So those are tests that tell us something about the survival probability or the progression-free survival probability, and then predictive biomarkers that tell us on a individual patient basis, looking at some aspect of their tumor or liquid biopsy, that they're more likely to respond to the treatment of choice. So that's a predictive biomarker, and then just some thoughts about precision medicine. So what about the patient who post-chemotherapy, and we're just looking at a prognostic biomarker, so cisplatin-based neoadjuvant chemotherapy, looking at the pathologic tumor response. I showed you about PT0. So Guru Sonpavde did a secondary analysis of the SWOG randomized trial and determined that with neoadjuvant chemotherapy, when the pathologic tumor stage was either PT1, PTA, or CIS or PT0, about a third of those were PT0, that they had a significantly improved benefit in terms of overall survival. So that, of course, doesn't help us in a setting where we're trying to pick patients to get neoadjuvant chemotherapy, but simply just an example of perhaps an expanded definition of benefit to PT less than PT2 post-neoadjuvant chemotherapy in that setting. And then if you look at just the patients, and these patients have, and this is just stratified, I think, by nodal involvement in the bottom curve. There's been a recent meta-analysis that was published in 2014 showing, again, this sort of same benefit to patients that are PT0 post-neoadjuvant chemotherapy. And then there's this concept that was really put forth by Cora Sternberg. She had a group of patients of about 104 patients that treated with chemotherapy alone. So they had TURBT chemotherapy, post chemotherapy TURBT, and didn't have either the PT0 or maybe they had carcinoma in situ, and they were observed. And a significant portion of those patients enjoyed long-term survival. That's clearly not the standard of care. So I'm sure that everyone in this audience who treats these patients has had patients who come in and they say, well, doc, you know, I have no more, you just told me that I'm cancer-free after the chemotherapy. Why do I have to have my bladder out? Well, if you look at the original neoadjuvant chemotherapy data from Memorial, fully 40% of those patients, as I recall, had residual disease that were CT0, clinical T0 post-neoadjuvant chemotherapy. So that was really telling us that these patients really did need to go on and have definitive surgery. Well, we tested this in a clinical trial. This was done by Lucky Lara and Rafe DeVere White. SWOG 0219. David Crawford will remember this trial. It was neoadjuvant chemotherapy, non-cisplatin based, just kind of taking a stab at a different regimen. And the patients who were clinical T0 had an opportunity to go on and perhaps not get a cystectomy, but what we found was that in the patients that did have a cystectomy, there was a 60% residual tumor rate, and that kind of put the kibosh, even though it was a small study, on this idea that patients were somehow cured with cystectomy. Now, if you wait a few slides, I'm gonna tell you, sort of fast forward, what at least part of the community is thinking about now. So now let's get into predictive biomarkers, and a nod to Dan Theodorescu and Tom Flagg, who's a medical oncologist at University of Colorado. So this is a SWOG study that's completed accrual. So Dan, a number of years ago, developed an algorithm that he calls Coxon, and it was essentially kind of a wedding, I mean, not a wedding, kind of a coming together, sorry, of 15,000 drugs in the NCI drug repository and the NCI 60 cell lines. So what he did is he did gene expression profiling on all the cell lines. By the way, none of them were bladder, and looked at sensitivity, predicted sensitivity for each of these chemotherapy drugs, and basically put an algorithm, a predictive algorithm together that he called Coxon. Well, that was then tested in a whole bunch of different data sets, but had never been proven prospectively to be predictive. So this trial is a validation trial of Coxon's predictive ability to identify patients who are going to be PT0 after either dose-densem-bac or GC. We've completed accrual. We're in the midst of doing all the gene expression profiling, and I think that these data will be available certainly within 12 months, hopefully sooner, and there's a ton of other cool translational stuff that we're going to be looking at in the context of this trial. So at least one approach to a predictive biomarker. This is very elegant work from Memorial by Ellie Van Ellen, who's a brilliant bioinformatist, medical oncologist, and they took two cohorts, retrospective cohorts, 25, all of them had neoadjuvant chemotherapy, 25 were PT0, 25 had residual muscle invasive cancer. They submitted into their MSK Impact 400 plus oncogene panel and found ERCC2 mutations associated exclusively with the PT0 response. So here was one of several looks at DNA damage repair genes and alterations identifying patients who are most likely to respond to cisplatin and other DNA damaging agents. And there will be a clinical trial coming out of the cooperative groups from the Alliance to test this strategy of identifying patients who, not just with ERCC2, but about 8 or 9 different DNA damage repair genes, giving them a cisplatin-based chemotherapy, and if they're PT0, observing them. Enriching a patient population who's highly likely to be exquisitely sensitive to cisplatin-based chemotherapy and may be able to observe. It's a very innovative, clever trial, and I think is really going to tell us a lot about the predictive nature of DNA damage repair and also the safety of observing these patients. I'll give a little tout to my colleague Keith Chan at Baylor College of Medicine, who did some very innovative work looking at other mechanisms of chemotherapy resistance and found sort of repair mechanisms mediated by prostaglandin E, by prostaglandin as a mechanism for resistance, and was able to overcome that with a simple COX-2 blockade with celecoxib. And that's now in a small phase 1 trial to do some validation work on this before, and if that's positive, going into a larger clinical trial. So multiple sort of ways to look at mechanisms of resistance, and more importantly, overcoming them with a variety of interventions. So you've probably, I think you've seen this slide. This is the TCGA Subtype version 1 from the Nature paper. This is the description of version 2, where we now have 5 subtypes and have much more precision around the three. We now have 3 luminal subtypes: luminal papillary, luminal infiltrated, and luminal, and then basal squamous and a neuronal subtype. And I don't have time to go into this, but this is a very nice diagram put forth by Gottfried Sodahl, who's really one of the world's leading authorities in this, from the Loon group, who really started this whole thing with molecular subtyping in muscle-invasive and non-invasive disease. And you can see how the field generally has coalesced around the binary stratification of luminal and basal, but we've quickly kind of learned a lot more about differentiating within particularly the luminal subtypes and understanding the biology of those, the gene mutations and the expression profiling of those. And I'll show you in a second kind of a back-of-the-napkin approach to what the future could look like if validated from a treatment selection standpoint. These are prognostic in terms of overall survival. This is a figure from the Cell paper in November showing that the luminal papillary has the best prognosis, the neuronal has the worst, with the luminal infiltrated, luminal and basal squamous somewhere in the middle. Some very clever work done by Roland Seiler, Peter Black, in collaboration with GenomeDx in a neoadjuvant chemotherapy setting, where if you look on the left, looking at the TCGA version 1 subtypes, and if you notice here in red, this is the basal subtype, so non-neoadjuvant chemotherapy. And in the neoadjuvant chemotherapy data set, they were basically able to take these sort of poor prognostic basal squamous, who we think are more likely to respond to chemotherapy, and sure enough, post-neoadjuvant chemotherapy, their overall survival looks more like luminal papillary, the best survival group. So another sort of piece of data in telling us a little bit about the potential predictive nature of subtypes, at least in the chemotherapy sense, and you've already heard about the potential in an Immuno Oncology setting. So this was the back of the napkin figure that, and I realize there's a lot of data here, but the way it's organized is, so we're comfortable with the binary stratification that's very consistent amongst every group that's done any kind of expression-based subtyping. At least in our hands, we were able to stratify this into 3 different groups characterized by these particular genes that are expressed, and then this is a low-risk group, so we think we can observe or perhaps treat them with FGFR3 inhibitors, because this is a very prominent a mutation in this subgroup. Luminal infiltrated by its very nature is immune infiltrated and maybe will respond better to immune-based therapy. This luminal group is a little bit more like the P53-like group from MD Anderson, a little more recalcitrant to both chemotherapy. We don't know if they're going to respond to immunotherapy, and maybe they're better for targeted therapy. Basal squamous could respond to both chemo and immuno, and then the neuronal we're going to treat like, or we would potentially treat like small cell neuroendocrine with those with etoposide platinum, which is kind of the current regimen. So in summary, I hope I've provided you at least sort of the nuts and bolts of the level 1 evidence supporting cisplatin-based neoadjuvant chemotherapy. There's really not high-quality evidence supporting adjuvant, so our attitudes in patients with adequate EGFR and no other sort of peripheral neuropathies that would limit them from getting cisplatin-based chemotherapy, we shouldn't rely on adjuvant unless they're upstaged and didn't get neoadjuvant. And while we're currently in a one-size-fits-all paradigm, I think the future is going to be changing fairly rapidly as we get these clinical trials done, really do the biologic assays, and get us closer to a time when patient comes in the door, sequence their tumor, you know, you go into this bucket, you go into this bucket, you go into this bucket, and hopefully that'll also translate to better outcomes in the future. So thank you very much.